Recording in
over
progress.
time may induce collateral vessel formation, and if your collaterals are functioning well, then these 75-90%, those margins and those limits will not affect that patient. Okay, so do you all understand that?
Yes, madam.
Okay. This extent and severity of dynamic plaque changes are, so pathogenesis, one is the atheroma, one is these dynamic plaque changes, where you can get either thrombosis or you can get vasospasm and things, but main thing is acute plaque change, right? So what happens with this dynamic plaque change? You have this soft necrotic lipid plaque. It can undergo either fissuring, that means it cracks, or it can undergo hemorrhage, bleeding, or rupture, or erosion, or ulceration. And then, like I mentioned, platelets adhere, get activated, and they release their various granules. And they aggregate over that cracked or fissured atheromatous plaque to form thrombi. And that thrombi will get bigger and bigger, and with more platelets adding to it. And so you get a thrombus, which may be occlusive, totally occluding the vessel or not. Yeah, does anybody, but you all can't hear me, is it? That's the problem? Sorry? I can't hear. I know that you all are telling something, but I can't hear what it is. What is that?
Hi.
Sorry? Sorry, what is that?
No, madam. I think someone was unmuted by accident. She's muted now.
Okay, all right. So these are the dynamic plaque changes, and you get this thrombi. And I have said microthrombi there, but actually they'll get bigger and bigger, right? And then it's not a microthrombus anymore. Maybe that's, yeah. So platelets release mediators. Now, the additional thing is that vasospasm might also contribute to narrowing. And tissue factor activates coagulation pathway, and it increases thrombus size, and it expands rapidly. Okay. So this is a famous diagram, which is from your Robbins. Here's your normal artery. Here's your fixed coronary obstruction, means over time as atheroma deposits, you get a fixed obstruction. Then what happens is you can get platelets aggregating here. If there is a rupture or if that plaque disrupts, you can get platelets there. And that can form, then on top of those, it can form a thrombus, which may be just like this with a little bit of the lumen patent, or it might completely obstruct, and here you get an actual myocardial infarction. Here, the patient may continue like this, so and have chest pain, but you know, if he exercises something, then he might, this might become bigger, and you might get an infarct, right? So, okay, so what are acute coronary syndromes? These are initiated by a sudden conversion of a stable plaque to an unstable plaque. So this plaque, which is nicely just, you know, there, this is when it becomes, here's a stable plaque, here's an unstable plaque where it disrupts, and therefore you can get a thrombus forming. So life-threatening atherothrombotic lesion through rupture and erosion and all that. Excuse me. So usually inflammatory change within the plaque precipitates the formation of this thrombus. And when you get a thrombus, you can get either unstable angina, and you will be taught about what that is and what the ECG changes and what the clinical presentation, or you can get an acute myocardial infarction, or you can get sudden death. Okay. So what are the things? Okay, here's stable angina. That means a stenosed coronary artery unable to supply increased myocardial demand. What is unstable angina? It is plaque disruption thrombosis. If you have vasospasm, then you will get constriction leading to severe transient reduction in the coronary blood flow. Okay, that is actually a continuation of the earlier one, but you can get spasm on its own. But usually with that thrombosis, you can get reduced lumen formation. The lumen, the patency of the artery reduces. Then you can get a myocardial infarction with acute plaque changes. It induces abrupt thrombotic occlusion and you get myocardial necrosis. Or you can get sudden cardiac death because in one area of the myocardium, it induces ischemia and induces a fatal ventricular arrhythmia. So they die suddenly, even before the myocardium has a chance to get necrosed. As it's getting ischemic, and especially if it's near the SA node, AV node branches, it might necrose, it might induce a ventricular arrhythmia and the patient will die. So what is angina? Angina is where you get pain, transient ischemia. Transient means for a short period of time, but it's insufficient to actually cause necrosis and cell death. So you get reduced blood supply to the myocardial cells, and so that causes chest pain, right? So stable angina is the commonest. It's an imbalance in coronary perfusion. Prince-Metal variant angina is where there is coronary spasm unrelated to activity, heart rate and blood pressure. And unstable or crescendo angina is there is increasing pain which is precipitated by progressively lower levels of activity, and they have some amount of myocardial damage. So let's say in January the patient can climb the stairs. By April the patient cannot climb the stairs because he gets pain, and by June the patient is having very severe chest pain at rest. Okay, that's a kind of unstable angina. Actually, it may not be January, April, and June. It's lateral. So crescendo means that it progressively increases, right? Okay, so here's your, so I keep repeating this because I need you all to know this. You get the atheroma and you get the blockage. And because it's blocked that part, you're going to get myocardial infarction in that area. So here's your coronary artery. So these branches are going to be okay. Nothing much happens. They will supply whatever myocardium. But this particular one might be occluded somewhere here. And then therefore that little bit of myocardium that it supplies will okay. So like I mentioned, in other patients you can get vasospasm, embolism, or due to various other types of diseases. Okay, so what happens when you have myocardial ischemia? There's immediate cessation of aerobic metabolism with decreased ATP production. Accumulation of lactic acid leads to immediate loss of myocardial contractility. And you have to note that only severe ischemia, that is 10% or less, lasting 20 to 30 minutes or more, leads to this myocardial necrosis. Therefore, it's very important that the moment this patient starts getting chest pain and all, that he is diagnosed early so that early intervention can be done in the hospital. So you can imagine, here's this patient, he has an occlusive thrombosis in that artery. Does anybody know what is the intervention that might be done if he gets there on time? Yeah? Yes? If you have a thrombus, what they do is they might do a thrombolysis, right? Where they give like things like streptokinase to lyse the thrombus, okay? And when you do that, what happens is that obstructed area of muscle regains blood supply, and therefore you establish what is called reperfusion, okay, to salvage that at-risk myocardium. I'll get to reperfusion in a little while, but this is something that can be done. So I'm just telling you about that to show you the importance of early diagnosis. Now, when you have myocardial necrosis, there is disruption of the membrane. You get various substances which are released into the blood vessels and the lymphatics. So you get troponin, you can get CK, specifically the MB fraction, you can get LDH, and also you can get things like myoglobin. So troponin and CK-MB are used, and you can see this, you can get in any book. They sort of rise at a particular time, they come down at a particular time, and they are absent from the bloodstream after a particular time. So depending on the time duration within which the patient comes, this can be used as a method to diagnose a myocardial infarction. Although I do want to say that the best way would be, well, you can look at an ECG, you got to look at these enzyme levels, okay, and you put it all together with the patient's clinical features. So here is the zone of perfusion. Here's your epicardial artery. Here's your endocardium if you take a cross section. And you can get a zone of necrosis. So here it's normal, then you get this thing, and then it might extend. Okay. So myocardial perfusion occurs from epicardium to endocardium, right? So the perfusion occurs that way. Therefore, it's the most vulnerable zone to ischemia. If you have ischemia, initially it's not this outer myocardium. It is this the endocardium, this subendocardial area, which is the most liable to ischemic injury, okay? And that is where irreversible injury occurs initially. Okay, now I want to tell you something about this concept of reperfusion injury. This is now you would think you have a thrombus, you lyse the thrombus giving streptokinase, and you re-establish the blood supply. And you would think that's a great thing to do. Well, it can be a great thing, but it can also be responsible for increasing the size of the infarct, because with that reperfusion, if you don't, that is why choosing which patients you thrombolize and which patients you determine not to thrombolize is a very important clinical diagnostic decision. Because if you thrombolize the wrong patient, you run the risk of increasing the size of the myocardial infarction, because reperfusion itself can cause further injury to the myocardium. So reperfusion injury is something very important. With the advent of all these different new treatments like thrombolysis, they are now seeing this kind of thing, not just in the heart, but in various places, right? Okay, so you just got to know that the reperfusion injury means it is tissue damage which is caused when the blood supply is returned to a tissue after a period of ischemia and hypoxia. Example, if you re-establish the circulation after thrombolysis in a myocardial infarction. Okay, so little bit about it. Now, I'm not going to do reperfusion injury here because I think it should have been done in the general path. Whoever did necrosis with you all should have done it. I think I told them to do it, and I think they would have done. I think Dr. Ali would have done that with you all. Okay. So reperfusion injury is caused by multiple things, including enzyme, white cells, complement, various other substances released. But one of the most important is what I'm going to talk about here, which are the reactive oxygen species, which are anyway normally generated by all cells, and that there is organisms in the body which are able to mop up those free oxygen radicals and prevent them from causing injury. Okay, so ROS are generated by cells, but they are normally scavenged, and the body does not, the myocardium and all over the body, you don't have injury. But in a patient with hypoxia, right, you have now, because ATP is now, there's reduced levels of ATP and the ATP can't be utilized. There is the accumulation of xanthine, which is a metabolite of ATP, which accumulates in hypoxic tissue and is oxidized by xanthine oxidase to generate free radicals. So your cells are generating free radicals, and this accumulating xanthine is oxidized and again generates free radicals. So there's a lot of free radical generated. Now, when you have ischemia, initially, ROS, these reactive oxygen species, free radicals, do not develop because there is no tissue oxygen, because the blood supply is totally cut off. However, when you re-establish the blood supply to the ischemic myocardium, you have a huge amounts of reactive oxygen species are generated both by mitochondria and this xanthine oxidase. As the energy dependent, your scavenging mechanisms are overwhelmed. Your scavenging mechanisms can manage regular things, but now this is a large area, it's overwhelmed, it can't manage, and therefore you get a huge amount of reactive oxygen species which are generated. So here's a patient who has had a myocardial infarction in the middle, let's say, and the tissue around it is like slightly ischemic but not dead. But when the perfusion is re-established, that initial central infarcted area now starts extending to that ischemic area, because in the ischemic area you start getting reactive oxygen species causing the reperfusion injury causes a whole lot of ROS, which cause further damage, right? So you can get extension of the infarct. Now, if you have chosen your patients to do thrombolysis on, if you've chosen them carefully, this won't happen. In fact, you might be able to control the size of that infarct very well and there won't be any injury. So reperfusion can either result in injury or not, right? So that's an important concept to know. So in reperfusion injury, tissue necrosis occurs not on cessation of the blood supply, okay, but on its re-establishment. Now, that sentence is a bit distinct because tissue necrosis has already occurred in part of it, right? But what we are talking about is in the other areas, in the ischemic myocardium, which has not yet died but is a bit vulnerable to death. Tissue necrosis will occur in those cells not because of cessation of the blood supply, but on its re-establishment. Okay? Did you all understand that? Can you all tell me? Are you here or have you all gone to sleep or what? Yes?
Yes, madam, we understand.
Did you all understand?
Yes, ma'am.
You're the only one who's answering. Why is nobody else? Come on, I want to hear 3-4 other people answer. Can you all at least say yes that you all understood?
Yes, madam, understood.
Right. 1, 2. Okay, 2 people. Any more? Any more people? Okay, 3. Any more? No more. One other person can't say yes.
Yes, madam.
Right. I don't know what's wrong with you all, but anyway. All right. So location of an infarct is determined by the size, severity, and the rate of development of the obstruction. And here, I think you better go and read up this anatomy. Left anterior descending is what it supplies. And the effects of obstruction will differ. The consequences differ whether it's a left dominant or right dominant circulation. So go and refer that. Size of the vessel bed is perfused by obstructed vessel. Then the location will also depend on the duration, metabolic oxygen needs, and like I mentioned, whether the collateral circulation is well developed or not. So if you have a collateral circulation which is very well developed, then you will have intercoronary anastomosis. So even if one coronary, the branches are blocked, you might have perfusion of that same area of myocardium by an anastomosis, and therefore the effects of the blockage will not be held, will not be noted, right? Then how extensive is the arterial spasm, and then of course heart rate, cardiac rhythm, then whatever other features, diseases the patients have. All right, so let's look at patterns of infarction. Here's your left ventricle, here's your right ventricle. And wherever, right, you can have a full thickness infarction. In this, it's a regional. It's called a transmural or full thickness infarct of the ventricle, here's the interventricular septum. Or you can have in one particular, it's a regional, both these are regional. A regional subendocardium. So here's your lumen, and the subendocardial region is very vulnerable. So that's a regional subendocardium. Or you can have a circumferential subendocardial, and you would get that in, like, say, if you get sudden hypotension or something, then you will, that is what you will get in that. Or you can have diffuse multifocal infarcts all over because there is fairly severe coronary atheroma, and you might have some, some of these might be due to thrombosis, some of these may be vasospasm or whatever, right? Okay, so if you take a full thickness transmural infarct, that is the regular atheroma, and then you have the thrombosis, okay, and it usually occurs in 6 hours. Approximately half the myocardium is usually infarcted in 3 hours, unless the collaterals are well developed, okay. Then if you have a subendocardial, like I told you, which is the inner third of the myocardium, that because it's the least perfused area and hence most vulnerable to ischemic injury, and that is if occurs due to a plaque disruption and thrombosis, which comes spontaneously or therapeutically lysed. So that thrombus that is formed, it might get spontaneously lysed by the body, by your fibrolytic system, or somebody might get streptokinase and lysed therapeutically. The other reason why you might get a subendocardial is, like I mentioned, in hypotension, where you have superimposed on a non-critical stenosis. Okay. Okay. Then what else? Multifocal microinfarcts occur where pathology involves only small intramural vessels, so like vasculitis, spasm, microemboli. Okay. All right. Okay. Here's a macro. Here's your left ventricle. Here's the right ventricular wall, and here's the lumen of the right ventricle. What do you see? There is mainly in this, actually there is a little bit of infarctive change here also, but here's your full thickness infarction, okay? There's a reddish area within the left ventricular myocardium, and it's involving this full thickness, okay, especially in this area. So this is probably the main area of the myocardium. Right, here's the time, here's the macroscopy or what it looks like, and here's the microscopy. So I don't want you all to memorize this like that, okay, but just a few things for you to know. Can you see that it's only after 12 hours that you can see any changes, and the changes are initially microscopic, where you have some early necrosis, edema, and you have a acute inflammatory reaction with polymorphs. So even though that's going on in the microscopy, macroscopically that heart looks normal. So if a patient has severe chest pain and comes to hospital and dies of a myocardial infarction about 8 hours later, and they say, we don't know why he died, and let's go and do a post-mortem, and you look at the heart and you cut the heart, when you open it and look at the myocardium, you're not going to find any changes because he died at 8 hours. Any changes are only going to be seen after 12 hours. So the only thing you can do is cut it and take some sections for microscopy and see whether there is any early necrosis and polymorphs. And obviously you will look at the blood vessels. You take some sections through the blood vessels and see whether there is any occlusion. Okay. Right. After about 18 to 24, just before 24 hours, there will be this dark, what is called mottling. You have like a hemorrhagic like area. And you will have some microscopic features of necrosis, right? So eosinophilic cytoplasm, nuclear pycnosis, karyorrhexis, all that, you still have the polymorphs. And in the myocardium, you have loss of striations of the contractile bands of the myocardium. Now, I have put a little asterisk there and I have said not to always, because now what's happening is, because of this reperfusion and all that, sometimes these striations may not be lost. Nobody's going to ask you about that. But I just thought, because it's in the books, in some of the books, and so you all might get confused when I say loss of striations. Somebody might say, no, you don't get it. So that's just a general thing to remember. Okay. After about 1 to 2 days, 1 to 3 days, that mottling is now becoming yellowish. And you're getting now, again, still you're having, now you can see large areas of coagulative necrosis. 4 to 7 days, you're seeing some central yellow area and softening. And you're seeing now myophytes are breaking down. And the polymorphs are now going, and you're getting now the predominant cell is the macrophage, although the macrophage would have come somewhere here. Okay, but it's still predominant polymorphs at 24 to 72 hours. But after about 4 days, now you find that polymorphs have gone off, and now it's the macrophages which are liquefying all that necrotic material and swallowing it, phagocytosing. Then around about 70 days, it's like yellowish, and you're now getting granulation tissue forming, because if you remember, myocardial cells are permanent cells, and therefore they do not heal by regeneration. They heal by repair. Sorry. So you have to get granulation tissue. Then you get a scar as the collagen increases and the blood vessels decrease, and then you get a sort of dense scar. These are very sort of this depends. It may not be 2 months. That will depend on the size of the infarction. So roughly you have to know. Okay. So here's early necrotic myocardium. This is in the early 24 to 48 hours. That's the kind of thing that you see, right? It's eosinophilic. You are not going to see any. There's lots of striations. The whole place is filled with sheets of polymorphs, and polymorphs are the predominant cell. Now here what has happened is this whole area you're getting granulation tissue. So this is, you're getting fibroblasts and you're getting lots of vessels. And here you're getting collagen, right? Here's your myocardium again. Can you see these white areas in the myocardium? What you see? In a healed scar. So you can see that he would have a transmural infarction some time ago, and he's had some myocardial scarring here as well. This is a full thickness scarring. This is some more. And the rest, now you can see the interventricular septum is perfectly being perfused, because you're not getting any problems there. And this right ventricle also looks, I think, okay. All right. So here's scar tissue formation. You're getting these large collagenous bands, and whereas earlier you would have got cardiac muscle. What are the complications? This you have to know. I'll do this very fast, because this is really to do with, in medicine, they will teach you all this and how to assess these patients and all. Initially, you can get cardiogenic shock and it can kill you. Okay. Or you can get arrhythmia, especially if electrical abnormalities of, ischemic myocardium is very, very unstable, and you can get very sort of, arrhythmias arising. Asystoles, bradycardia, supraventricular tachycardia, fibrillation. Fibrillation can kill you. Fibrillation should have 2 L's, by the way. Then left ventricular failure, impaired contractility of the ischemic myocardium. So if there is a huge full thickness infarction of the left ventricle, then you can imagine it will fail, obviously, and the patient will have pulmonary congestion and edema. If the infarction involves a papillary muscle, obviously it can't function well. You get dysfunction, and you can get, if it's at the mitral, that's the left side is common, you can get mitral regurgitation and failure problem. Or you can get acute mitral insufficiency and failure. Very important, rupture, especially full thickness infarcts. 4th to 7th days, the myocardium has now been necrosed. The polymorphs have come and liquefied the whole thing. The macrophages are trying to digest it all up. But when it's liquefied, it's so soft. And if the granulation tissue doesn't have enough time to form, at that time, if it's very, very necrosed, it will soften and rupture. So the rupture is maximally 4 to 7 days, but anytime during that first 2 weeks, right? Anytime during the first 2 weeks, you can get rupture. And so you got to watch out for it. Most common is left ventricular fibroid rupture. It occurs in females over 60 with anterior or lateral infarcts. and it can rupture. If it ruptures through into the pericardium, you can get an acute hemopericardium and death due to cardiac tamponade, because there is an obstructive contractility of the heart, often fatal. If this ruptures through the interventricular septum, then it's like having an acute VSD, and the patient can go into acute heart failure. So this is a very, very important complication. You can get, now when you have an infarction, you can, that now this is in the myocardium, but the adjacent pericardium, you can have inflammation of that. So you can get an acute pericarditis, occurs within 2 to 4 days in that acute stage, but it usually resolves unless the infarct is massive. Okay. You can get a chronic pericarditis, which is really an autoimmune related thing. It's called Dressler syndrome and occurs 2 to 6 weeks after the infarction. Please go and read up about that. Much later, when this infarct has undergone fibrosis, scar formation and repair, and the heart now continues to pump, but that fibrous tissue cannot, obviously, it is not contractile. Therefore, you will get ballooning out of that area, and then you get like an aneurysm being formed in the ventricle. Okay, that's a late complication. I'll show you all these pictures, okay, in a minute. So you can get, especially following a large transmutation or anteroseptal infarct. You can get neural thrombi within the aneurysm because there is stasis there. You can get embolism. Neural thrombi may develop over the endocardial surface of that, and they may embolize all over. So you can get a stroke if it goes to the brain. If you get, if it goes to the gut, you can get acute gut ischemia, bowel ischemia. You can get renal infarcts if it goes into the renal arteries. You can get popliteal, iliac, popliteal, femoral vessels. From there, you can get embolism, and you can get infarction in the leg, right? Intermittent claudication and infarctions. Okay, so here they are. Here's your papillary muscle. If it ruptures, you can see what happens. You can get heart failure. Or if you rupture the ventricular septum, you can get something like a VSD. When you get an aneurysm or thinning of the wall, you can get thrombi form, and those thrombi can form emboli. You can get a fibrinous pericarditis. You can get myocardial fibrosis, these white patches. But if that in the 4th to 7th days or in the first 2 weeks, if that myocardium ruptures, you can get blood leaking outside into the outside, and that impairs the contractility of the heart. You can get a cardiac tamponade. In the ventricular wall, you can see this is thin. This is the thickness of the myocardium, but in this area there has been an infarction. There's been lots of fibrosis. You get a huge aneurysm. You can get an aneurysm, and you can get thrombosis of that and embolism. Okay, right. So here's a summary. Myocardial infarction is death of part of the myocardium, usually due to occlusion of the coronary artery. The occlusion is usually due to atheroma with thrombosis. Myocardium undergoes coagulative necrosis. Release of enzymes from damaged cells is useful in diagnosis of an MI. Healing occurs by scar formation. Multiple complications may occur during the entire process of injury and repair. Knowledge of these complications is vital for proper management of these patients. That's the end. Did you all understand that? Yes, no?
Yes, madam.
All right. Okay. So that's it. I have finished. Any questions? I thought you might have a lot of questions. You all don't have any questions, is it?
Madam, following MI, can there be aneurysms in distant places as well in the?
No, that is you're thinking of infective endocarditis, right? Following MI, you're not going to get aneurysms. Okay, aneurysm is in that local area, right? But in infective endocarditis, you can get what are called mycotic aneurysms, but that's a totally different thing. Have you all had a lecture on mycotic aneurysms? Have you all had a lecture on infective endocarditis?
No, madam, not yet.
Okay, you will give somebody gives you that lecture, then you will understand, right? But aneurysm is a local thing, right? It's related to the fact that the myocardium is damaged. It is replaced by fibrous tissue. Fibrous tissue does not contract. Therefore, with the normal contraction of the heart, that area where the fibrous tissue repair has occurred, it starts ballooning out and forms this little pouch-like thing called an aneurysm. And because there's stasis of blood in the aneurysm, you will get thrombosis of the inner wall. From those thrombi, you can get little emboli. And those can go and lodge in various arteries all over the body in the systemic circulation. And you can get infarctions all over. But that has nothing to do, you don't get aneurysms all over, you just get infarctions all over. Okay?
Okay, ma'am. Thank you, ma'am.
Right. Welcome. Any other questions? None. All right. Then I'm going to stop. Okay?